Thank you, Jackie. That was a wonderful presentation. I'm going to introduce our next speaker, Dr. Avihu Gazit. He is our chief pediatric cardiac he is the chief of our pediatric cardiac care medicine program, professor of pediatrics, and the director of our cardiac care unit, along with the co-director of the Heart Institute. He is going to be speaking on postoperative complex transposition repairs and how to progress through the CICU.
Thank you, Yvonne. Thank you for inviting me. As you can see here, what I'm going to talk about is how to progress through the ICU, and specifically that this is not really rocket science. So before the child gets to the cardiac ICU from the OR, I think it's important to mention several points that would affect the downstream postoperative care. A lot of people mentioned already that this right ventricle is hypertrophied, secondary to prolonged systemic loading conditions, and that would definitely have an effect on the postoperative care. Relatively long cardiopulmonary bypass and cross-clamp times because of the nature of the operation, the complex nature of the operation. Potential coronary artery distortion secondary to mobilization and reimplantation. Risk of postoperative AV conduction defects and arrhythmias. As the child finishes the operation, gets off a bypass, it's critically important to assess for segmental wall abnormalities, signs of ischemia, aortic insufficiency. That's done with our expert colleagues with a TE in the OR. And as the child gets to the CICU following that, assuming that those were not significant findings, we perform a 12-lead ECG and an AEG routinely. We need to, when the child arrives in the ICU and we sign out, we need to take into account the effect of residual anesthesia and neuromuscular blockade on the clinical state of the patient, the effects of the cardiopulmonary interactions between mechanical ventilation or positive pressure ventilation and the loading conditions, and the effects of vasoactive infusions on the hemodynamic profile of the patient. This is a large laundry list of what we anticipate as problems during the first 12 hours after cardiopulmonary bypass. This is not necessarily unique to this subpopulation of patients, but there are some specific items that I think are worth mentioning. Obviously, pain. The diastolic RV dysfunction becomes a significant issue in those patients since they have an hypertrophied RV from the get-go, and then they're exposed to cardiopulmonary bypass, which makes it even more sluggish after that. Definitely some expected some hemodynamic lability, inadequate systemic oxygen delivery, the low cardiac output syndrome needs to be taken into consideration. Capillary leak, third spacing, vasoplegia, blocks or arrhythmias if they occur. And then, again, the initial phase, these patients will be intubated, and therefore there will be some significant cardiopulmonary interactions that would affect the RV preloading and the afterload to the RV. Post-cardiopulmonary bypass AKI and oliguria is pretty much expected following those complex operations. Bleeding, coagulopathy, hypoglycemia, and adrenal insufficiency. Nothing you have not heard before. And then in order to understand the clinical state of the patient, we do need multiple modalities to monitor those, some of them invasive, some of them are non-invasive, and of course biochemical markers. Again, this is not rocket science, and those are routine things that we all do, so I'm not going to get into details right now. It is helpful to have everything in front of our eyes in a dynamic way in all those platforms that allow for high-resolution presentations of multiple streams of data at the same time. So hemodynamic data, ventilator data, and the biochemical markers. The first 24 hours. The clinical targets for inotropics and vasoactive infusions are, again, not something that is unique. To maintain adequate systemic oxygen delivery, this is key for every cardiopulmonary bypass patient. Maintain adequate coronary perfusion pressure. This is true for every patient, but definitely for those kids that underwent this type of complex operation with the translocation of the great vessels. Avoid tachycardia, and the reason for that is the diastolic dysfunction of these ventricles that require slow filling. So tachycardia will definitely be detrimental for those kids and something to be aware of as we care for them. Avoid hypertension to protect complex sutures and promote lusitropy, again, for the diastolic dysfunction nature of those RV. And if there is AV block or arrhythmias, then we take care of them as well. As far as the sedation analgesia targets, so the main thing is really to progress them pretty quickly, but the first postoperative night with all of these hemodynamic issues, we do expect them to remain intubated, and therefore they do need to be a little bit more sedated. We target a state behavioral score. Some use the RAS goals of -1 or even -2 to optimize tolerance of the endotracheal tube and minimize oxygen consumption. We try to avoid the neuromuscular blockade to expedite ventilator wean. Not always we can do that. If they're really marginal and their oxygen delivery state is pretty marginal, you sometimes need to do it in the first night. And then the common combinations we use, and this is, again, not unique, are phenethylamorphine and dexmedetomidine. We try not to use benzodiazepines as first line because of the negative inotropic effect of benzodiazepines with the benzodiazepine receptors in the myocardium, as well as the anxiolytic effect that might decrease their sympathetic tone and create hypotension. So we try not to do that, not to mention the delirium associated with benzodiazepines as well. In the first or second postoperative days, in preparation for extubation, we start peeling off all these sedations, minimizing them, and post-extubation, we transition them to PRN morphine, although in some cases you do need to continue at very low dose narcotics to facilitate their recovery. As far as clinical targets for mechanical ventilation, again, the goal is to really expedite their extubation. With the cardiopulmonary interactions, with the positive pressure ventilation and this RV that's dysfunctional, it's really important to aim for functional residual capacity. So avoid high mean error pressures and high PEEP to optimize RV preload. We try to, in that vein, we try to wean to spontaneous ventilation as soon as overall clinical status allows. And we aim for early extubation, day 1 or 2. Again, depends on other factors such as fluid overload and diuresis. As far as fluid balance and urine output, this is really key. And there are people that think that this RV is dysfunctional. There is restriction of the RV, so you need to load them with a lot of fluids in order to optimize their preload and optimize cardiac output. But sometimes that works against you. And especially in those complex transposition or any transposition for that matter, loading it with a lot of fluids and very fast might actually create some geometrical changes to the coronaries and might create some ischemia. You don't want that. And also, when you load them in a lot of fluids, you create myocardial edema that worsens their diastolic dysfunction and may lead to worse coronary perfusion pressure, which I'll discuss as well. So in short, you want to be less aggressive about fluid resuscitation and more aggressive about early initiation of diuretics in those kids. Always take into account adrenal insufficiency and hyperglycemia. This is more significant in the neonates and these operations are usually done more at several months of age or even later, but you do need to take that into considerations. Definitely hyperglycemia after those long bypass runs is a common problem that you need to be aware of and address as per your institutional process. Usually, if we have glucose levels that are greater than 200 for a couple of draws, we use regular insulin infusions to control them. As I said, the key, and this is not specific to complex transposition, for every post-bypass case, is to optimize oxygen supply and demand in those kids. And this is very common, and you all know this graph, but I'll just go over it very quickly. On the y-axis is oxygen uptake, and on the x-axis is oxygen delivery. And prior to bypass, at the pre-bypass state, when the patient is still waiting, they have luxurious oxygen delivery. And you can see that the ratio between oxygen delivery and oxygen uptake is pretty high, actually. It's greater than 4:1. So in this state, the uptake is definitely not supply dependent. But post-bypass, when the patient returns to the ICU, after a prolonged bypass run, you do expect decrease in their oxygen delivery overall. So you go left here on this line with decreasing of oxygen delivery. And as the oxygen delivery decreases, you're still supply independent, but your ratio between DO2 and VO2 goes down. And if you are not aware of that and you don't reverse that, you are going to get to this critical point where uptake becomes supply dependent, and this is not good. This is where the cells become oxygen hungry. This is where dysoxia occurs, and this is where lactate starts increasing. You really don't want to get to that point. Unfortunately, it's really hard to assess that without, because this is really kind of something that you don't see overtly. You cannot rely on lactates to tell you anything, because they are elevated in the OR because of clearance issues, and again, they will not rise significantly until you get to this point. So you have to rely on other things. What you rely on is biochemical markers. Unfortunately, biochemical markers you can't really get continuously. So you get VO2s and blood gases every hour or so, or every 2 hours. That's not enough to really tell you what's going on. So there's other measures, other non-invasive measures that we can use to understand this process a little bit better. And and this is the near-infrared spectroscopy that has become state-of-the-art in the majority of the units across the nation and internationally as well. Near-infrared spectroscopy is wavelengths of about it's actually 600 to 900, but it's the usual devices look at 700 to 900 nanometers. People started to use that in vivo in humans in 1977 and in neonates in 1985. So it's been there for a while. It's been there for 40 years or so. The benefit of NIRS is that the biological tissues are relatively transparent to the near-infrared light, and that there are chromophores in the tissues that changes their optical profile when the near-infrared shines on them, and that depends on their oxygen status. So for example, hemoglobin is a chromophore, oxyhemoglobin is a chromophore. And the cytochrome AA3 is a chromophore. So these are in that area here. They have specific and very unique profile that allows you to differentiate between them. And as you can see here, the peak hemoglobin absorption is at 775 nanometers, and at that point, there is a significant difference between the oxy and deoxy hemoglobins. So you can differentiate between them and understand what your oxygen state in the tissue is. On the right, is an example of cerebral NIRS. This is the probe there. You can see there is a light source. There are some deep and shallow detectors. And the NIRS detects oxygen, those chromophores, the hemoglobin and deoxyhemoglobin, at a volume of about 1 cubic centimeter. And that's true for every region in the body. These regions are usually more rich in venous blood than arterial blood. And based on studies, it's about 2/3 venous predominant, which makes it more of a surrogate for central venous saturations. There are multiple studies that actually shows that cerebral NIRS correlates pretty well with the jugular bulb saturations. So we do use it as a surrogate for systemic oxygen saturation or central oxygen saturation. It's important to remember that we use multi-site NIRS, so we use the NIRS on the head, NIRS on the body, and the different regions are regulated differently. It's important to remember that the cerebral NIRS or cerebral blood flow is regulated by autoregulation, whereas the somatic NIRS is regulated by sympathetic tone. And remember also that the cerebral NIRS, the cerebral oxygen extraction is higher than the body at baseline, so you'd expect the cerebral NIRS to be lower than the somatic NIRS. That's really important. With this study that was conducted in Wisconsin, and showing that at baseline there is a difference of about 20 between cerebral NIRS and somatic NIRS, where the cerebral is lower. But as you go to the left there, and this difference decreases and sometimes reverses, you get yourself in trouble. You have more incidence of any complications, biochemical shock and mortality. And I brought this here as well. This is the T3 screen that shows the dynamic nature of the NIRS when there are changes in the clinical state. This is the cerebral NIRS in light there, and then the blue is the renal NIRS. And you can see that as the heart rate increases, there are a lot of variability here in pulse ox. This is single ventricle patients in this case. You can see that there is a reversal of somatic and cerebral NIRS, which makes you feel that you're not doing very well. You have to reverse that. In this case, it was reversed. The heart rate goes down, and they reverse again and become normal. So this gives you an idea of the dynamic nature of NIRS and how much it helps you on a second basis. Coronary perfusion pressure. So all of us are talking about that. We need to maintain adequate coronary perfusion pressure, which is the solid blood pressure minus CVP. But what exactly is a good coronary perfusion pressure? You look at the literature, no one actually knows. I found a very nice study that was done in Boston that looked at about 4,000 patients and looked at those that were post-cardiopulmonary bypass, those were children, and look at about 300 of them that had complications. And then they used the T3 for that as well and calculated the coronary perfusion pressure every 5 seconds, then looked at those adverse outcomes, CPR, ECPR, ventricular assist devices, unplanned surgery, heart transplant, and death. And they found that coronary perfusion pressure greater than 35 millimeters of mercury was protective against the outcomes. Again, this T3 provides you with continuous measurement of the coronary perfusion pressure by continuously deducting the diastolic and the CVP. So I'm getting to the summary. I'm almost done here. Some major physiological aspects that we need to focus on. First is the restrictive RV physiology. Second is the vasoplegia that's driven by the bypass and adrenal insufficiency. The restrictive RV physiology leads to elevated CVP, which will decrease low coronary perfusion by itself. The vasoplegia leads to low diastolic blood pressure, which will also decrease the coronary perfusion pressure. There will be low MAPs as well with the vasoplegia, which will lead to low renal perfusion pressure. This is determined by the MAP minus the CVP. That will lead to oliguria, fluid overload, myocardial edema. All of those things will lead to elevated CVP, which will, again, lead to decrease in coronary perfusion pressure. And then for positive pressure ventilation, which will increase the intrathoracic pressure, which will decrease the transmural pressure in the right A, and also lead to elevated CVP and lead to low coronary perfusion pressure. So you want to break those things by vasopressor and steroids to decrease the effect of vasoplegia, by early initiation of diuretics to address this fluid overload, the myocardial edema, and by extubating them quickly to decrease the effects of positive pressure ventilation. So in summary, rapid ICU liberation is possible and beneficial in patients following this very complex operation. Identifying low cardiac output syndrome early and optimizing oxygen delivery, maintaining adequate coronary and renal perfusion pressure, early initiation of diuretics, and early narcotic sedation, ventilator wean, early extubation are what's needed. Thank you.